Before we jump into content, just a couple of introductions and housekeeping items. My name is Brooke. I'm a speech pathologist here at Tim's Medical, and I am excited and honored to have Selena Reece with us this evening discussing the art and science of fees analysis. If you are joining this webinar and wish to obtain ASHA CEUs, this course is eligible for 1.5 PDHs or 0.15 ASHA CEUs. In order to obtain ASHA CEUs, we ask that you stay for the duration of this presentation and then complete a brief survey. I'll put the survey link in the chat, and then it will also be sent out via Zoom email. But if you don't get it, no sweat. Just send us an email at tims-univ@tims.com and we'll get that over to you. We do ask that you complete that survey within 7 days of this course offering so that we can get your information over to ASHA. And then if you would like a certificate of completion, just send us an email at tims-univ@tims.com. And with that, I will hand over the floor to Selena.
Thank you, Brooke. Hi, everyone. I'm so excited to be here this evening to present to you. The presentation for today is the art and science of fees analysis. So if you're interested in learning about fees, buckle up. We're going to jam through a lot of important content in the next hour and a half. Let me see. Oh, there we go. So I'm Selena Reece. I live in Raleigh, North Carolina. I am a Tar Heel. I graduated from the University of North Carolina at Chapel Hill with my master's. I spent my early career working in the acute care setting, and I've been doing on-site fees for about 16 years now, transitioning to the role of Director of Education with Patheus Health, formerly Carolina Speech Pathology. I've been fortunate to be able to do fees training all across the country, as well as mentorships as a part of this role. And when I'm not talking about dysphagia, I love spending time with my family and my dog, a little rescue pitty named Pickles. So here are my disclosures. I'm really happy and thrilled to share that I am grateful for a salary from Patheus Health, LLC. I just accepted a position as adjunct faculty with the North Carolina Central University, and I'm also grateful for compensation for this webinar from Tim's Medical. Non-financial, I do volunteer for some committees within ASHA and the American Board of Swallowing and Swallowing Disorders. All right, so learning objectives. Hopefully after this talk, you will be able to explain how non-swallowing tasks can enhance our fees interpretation, list tools that can be used to improve our reliability for fees interpretation. We'll be able to talk about laryngeal abnormalities and indicators for a laryngology consultation, which I think can be the trickiest part for new endoscopists. And we will actually utilize interpretation tools for fees analysis. So here's the agenda. I packed a lot into this webinar, so I'm going to try really hard to get through everything quickly. If you do have questions or if I'm going too quickly, feel free to put them in the chat. And then if there's content that we just can't get to tonight, I'm happy to email information to Brooke to pass along to you all. So the history of fees in 1983, Dr. Jerry Logeman was the first to bring the modified barium swallow study to speech pathology practice. And later in 1988, Dr. Susan Langmore published the very first paper introducing fees. Shortly after, in 1991, fees was added to ASHA's scope of practice. And then in 1994, the CPT code was initiated by CMS. In 2001, Dr. Langmore published her first book that's kind of like the fees Bible. It just outlines performing fees from start to finish. In 2014, this was actually the first year that there were more fees procedures billed to CMS than modified barium swallow studies. And then in 2022, a fees task force was published to create the latest and greatest fees competency guidelines. For a deeper dive into the history of fees, there is a webinar, a Tim's University webinar in the archives that was taught by Lori Winterholm and Aaron Padilla, and that they reviewed this really nicely. We won't really spend a lot of time on this. Additionally, I know Brooke is doing a webinar later in September that will talk a little bit more about the components of fees and dive into the history as well, as also providing resources for building a fees program. Fees and modifieds are both gold standard procedures for identifying tracheal aspiration, laryngeal penetration, pharyngeal residue, appropriate diet levels, as well as compensatory techniques for swallowing. There are pros and cons to both procedures, but I'm really here today to talk to you about fees, so we'll spend most of our time talking about that. The purpose of fees is to provide a functional and comprehensive swallowing exam. We're able to have direct visualization of the larynx and pharynx and can determine the presence of abnormal swallowing physiology. We can determine the effectiveness of postures and maneuvers, as well as bolus adjustments for improving swallowing safety and efficiency. And then we're also able to make recommendations based on our findings to support nutritional intake and any interventions to improve overall swallowing safety or function. So the knowledge and skills that are needed to work with patients to perform fees is obviously we need to have a comprehensive understanding of swallowing physiology. We need to understand dysphagia and the medical conditions that can be tied to a dysphagia diagnosis. We also need to have some core skills of understanding normal versus abnormal anatomy and being able to make real-time decisions on how to navigate a fee study based on our patient's performance, as well as applying interventions when necessary. I would like to point out here that ASHA has no set guidelines for fees competency. The latest paper with the fees task force that's cited on this slide is really the best go-to guideline for fees competency training. Keep in mind some states do have some specific requirements for fees competency. So if you're new to fees, make sure that you double check your state. If they don't have any mention of fees, then defer to ASHA. Some examples are Virginia has some specific certification requirements, as well as California. So make sure if you're in those states, you do a double check. There's also a resource on ASHA. If you do a quick search on the ASHA website, they have a link to states with specific endoscopy requirements, and that will then link you to the state that has those requirements. So let's get into it. I'm going to talk most of this presentation breaking down the fees protocol. The idea of a fees protocol was first outlined by Dr. Susan Langmore in her first publication in 2001. And in my practice and our mobile fees, we still use this today. This protocol involves 3 parts. Part 1 is the anatomy and physiology assessment. Part 2, the assessment of swallowing, and part 3 is the assessment of intervention. So during the anatomy and physiology assessment, we're just really getting a baseline picture of our patient's anatomy. We're going to just take a peek at the structures at rest, just make sure everything looks symmetrical, make sure the mucosa looks really healthy. During this time, we're also going to be observing secretions and any spontaneous clearing response to clear out secretions. And we are going to be performing non-swallowing tasks before we start introducing bolus trials if we can. Not all patients tolerate this, but if we're able to, this really gives us an idea of how the swallowing physiology is working without the pressure of a bolus. So what is recommended by Dr. Susan Langmore is to first look at velopharyngeal closure. You'll do this by alternating between oral and nasal sounds. So dunna, dunna, donut, donut, things like that. To assess the base of tongue, which as you push the scope a little farther down, you'll be able to see the base of the tongue, and you'll have your patient say ball, 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 Earl, 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 Paul is tall, getting those nice base of tongue movements. And again, we're not measuring, the amount of strength, but we're just looking for how robust is the movement and is the movement looking pretty symmetrical. Pitch glides are a really excellent way to look at pharyngeal constriction, and there has been some research to support this as well. And then we'll be looking at the larynx, having our patient phonate E, he, E, to really look at abduction and adduction. And then last, we do a breath hold. In our practice, we follow Dr. Susan Langmore's guidelines of a 7-second breath hold. This is to see if the patient has the ability to hold their breath long enough to support sequential sips. And then last, the sensory component. Does the patient note the presence of the endoscope? Are they performing reflexive swallows in response to residue? Are they responding to airway invasion? So you can surmise information about sensation by what's happening during the exam. In 2014, Dr. Kanioka did a study where they did a simple touch test and found that it was effective at identifying sensory loss that is associated with airway invasion. Before that, there was FEAST, which was fees with sensory testing, but this is no longer clinically available. And so, so you can do this touch test. I will say I don't often do it in my practice. I don't gag my patients during a bedside swallow exam. And so I don't really like poking around if I don't have to during a fees study, but just be familiar with that research and know that that is an option available for you. So we really need to be familiar with the structures that we will be observing during our study. We are not making a diagnosis about anything structural. We're just observing and documenting anything that might be a little bit off. So it's really important that we become familiar with normal versus abnormal. And I won't read everything on these slides. You will get these slides via email, and I believe Brooke will also have them available on the TIMS website to download. So if you don't have them now, you will have a copy of them, so you can read over all of this. And then while we're observing the larynx, we'll see some subtle movements of the glottis that mirror inhalation and exhalation. And we will take care to look at the completeness of glottic closure by having them phonate, like I said in the previous slide, say E. And that's a really important thing to test to make sure that our patient is able to achieve that airway protection to support swallowing. And then, making sure that we do get a really nice subglottic view if we can. Looking at the anterior trachea down to the first tracheal ring is part of what we try to do during the post-swallow position or the deep position when we're scoping. Sometimes we're not able to catch this view because of anatomical variance, patient positioning, secretions. And so if you're not able to visualize any of the structures listed, I just document in my report why I can't comment on those structures. Okay, so I'm going to start by playing a video of non-swallowing tasks. So this is Dunna, 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 Dunna. And so you can see pretty robust VP closure. We're down in the pharynx. Now we see the lateral pharyngeal walls moving inward during pitch glides. Sustained ease. He. Ball, ball, ball. You can see the base of the tongue retracting. Those movements are robust and symmetrical. This is a whoop boom, which some people see to kind of really look at the way the pharynx moves and then opening up those piriform sinuses. And now there's a sustained breath hold. So you can see the glottis is closed tightly and the endoscopist has counted for 7 seconds. So this person has a pretty normal functional looking baseline. And so I don't have any hypothesis of what any type of problem that I might see with their swallowing. So let's look at what an abnormal non-swallowing task might look like. So we're kind of passing the scope through the nose here. You can see that the mucosa, it looks just a little bit dry. It's kind of red, passing through. It looks a little healthier as we move back. And once we get just above the VP port, we have the patient say donut, donut, and you can see that movement is not complete. It's not robust. But then when we cue them to swallow, as you can see, we got a really nice tight VP closure. So sometimes the non-swallowing tasks that you ask your patient to perform might not yield as robust of a movement as you get with a swallowing task. So keep that in mind. This patient is phonating, and so you can see there's a little bit of hyperadduction of the ventricular folds. Those ventricular vocal folds are just sort of moving inward and just giving a little help to achieve that full glottic closure. Okay. So here's another one. I kind of gave you the answers on the side here. This is a patient that is, we're cueing him to say E, he, and there is just no glottic closure. There's no approximation. The arytenoids are trying to move toward midline. However, we're not really getting achieving that glottic closure. And as you can guess, this patient's voice is just like a whisper. It's almost completely aphonic. And so, so as I'm doing these non-swallowing tests, I'm going to hypothesize that they're very likely going to have diminished airway protection and has a pretty high likelihood of having some aspiration. And so you can tell a little bit of difference in the image here. This is a distal chip scope. So Brooke in her webinar will get a little more into equipment, and I believe Lori and Aaron went in a little bit more to the components of fees, but you can see the difference between what a fiber optic scope image looks like and a distal chips image looks like. And so this is a distal chip image, so it's a little bit more clear, and you usually see a square or a rectangle rather than a circle, and that's another clue to know that this is a video scope. So let me play this one for you. And so if you look up high, you can see that there's some bulging, kind of larger pharyngeal tonsils moving inward. We have a nice, I'll play that again, that was a short clip, a nice long uvula that's kind of kissing the tip of the epiglottis. And we're asking this patient to phonate, and you can see that the right arytenoid is moving, but that the left arytenoid, it almost has that hooded appearance, and it appears to be immobile. We haven't really gotten into talking about secretions yet, but you can see there's some frothy secretions that are hanging out back in the posterior cricoid space as well. So quite a few things going on here. Okay, so those are the non-swallowing tasks. And there are some patients who are just like, hey, let's just get right into the POs. And so sometimes I'll do my non-swallowing tests in the middle or toward the end of the study. But ideally, I do like to do them at the beginning because they help me kind of decide, hey, what texture might be the best to start with, and what do I think I'm going to see during this exam. So we're still in part one, still in the anatomy and physiology exam, but now we're just going to talk a little bit more about describing abnormalities. So it's crucial to know what is normal and what is abnormal or an acceptable variant when we are starting to perform fees. And we need to know when something warrants an ENT workup. My recommendation is if you're on the fence, if you're not sure, when in doubt, refer it out. We also say when you're unsure, refer. So just keeping that in mind, if you're just like, I'm not really sure, it's better to over refer than to under refer most of the time. We certainly don't want anybody to slip through the cracks that has something that really needs the attention of a physician. They did a study, Dr. Pazik and colleagues, they did a study, it was retrospective in nature, and they looked at 75 patients who were admitted to a community hospital who failed the swallow screen. And of those patients, of those 75 patients, 39% that received the fees had laryngeal abnormalities. Some of these were just, unilateral vocal fold immobility, fungal infections, vocal fold lesions. There were some granulomas, I believe. But one of these patients, they actually found cancer. And in the thousands of fees that I've done in the mobile fees setting, I have unfortunately identified, lesions that did end up getting to ENT and being a cancer diagnosis. So we're often the first to look inside a patient's throat. And so it's really important for us to know when to really push for that referral. And so this is something that I strongly encourage. Don't be afraid to say, I'm not sure, because we really would hate to miss something and miss getting a patient, the diagnosis and toward a path of treatment if we need to. Okay, hopefully in your hospitals or facilities, you have the ability to put images into your reports. If not, you have the ability to reach out to a physician and maybe show them the pictures. I found that that's a really good way to learn. When I was early in my career, I would talk to my ENT friends and learned a lot about what was a normal variant and what really warranted a referral. And so, even if we are providing images in our reports, it's also really helpful to make sure we're describing things really well. It's important to document the size, the texture or shape, the mobility of the abnormality, the color. You can use broad descriptors like protrusion, mass, lesion, etc., and location. We have to go back to our anatomy classes and remember unilateral, bilateral, superior, inferior, midline, etc. You can say adjacent to or at the level of. But the more detail you provide, the better. And so there's just a list of some examples of adjectives that you might use. So one of the most common findings with fees is inflammation. And inflammation can be, when I first started doing fees, we always kind of chalked it up to reflux, but inflammation can be there for a lot of other reasons, and I've listed those in this slide. Dehydration, allergies are two big ones. I was trained on the reflux finding score, and I found this to be really helpful to discern when inflammation is present. However, in personal communication with one of the authors, he used to serve on our advisory board, Dr. Greg Postma, he said, gosh, I wish we'd never called this the reflux finding score. It's really the inflammation finding score. And so, just because somebody has inflammation, it doesn't always draw a line to laryngopharyngeal reflux. So keeping that in mind. Some people give the reflux symptom index to kind of go hand in hand with this reflux finding score. But we really just use it in our practice to determine how inflamed somebody is, if it gets worse on their repeat, or if it's consistently staying the same, and kind of put that in there and see if there's not something that we can connect it to, if they're having any symptoms that gets addressed. There's also the revised Patterson edema scale. The Patterson edema scale was first developed for ENTs for rating inflammation for head and neck cancer patients. But a few years ago, Dr. Heather Starmer did research to show that speech pathologists use this really beautifully. I haven't used this in my practice, but quite a few SLPs that I've asked are using it, even not in the head and neck population. So that's something to look into as well as you're looking for ways to kind of keep yourself honest as far as scoring inflammation. Sometimes it feels like everybody has inflammation, and making sure that we're rating that as consistently within your practice. Inter and intra rater reliability is good. So both of those are examples of rating scales you can use for that. Brooke, have there been any questions so far? Are we doing okay? I'm going to keep going unless she chimes in. Okay, so describing variants and abnormalities, I just have a couple of examples here of some common things you might see, or maybe some things that you would maybe call your ENT colleagues for. So this first image, as you can see, is a pretty healthy larynx, but the uvula, the tip of the uvula is actually touching the tip of the epiglottis. So this could just be, the way this person has grown. But I would, when I see this, just look and see if there's a palatal droop. And if you can kind of look past that, you can see that there is a little bit of increased either edema or movement. This is a still, so I'm not sure if this patient's moving or not, but the ventricular fold is almost completely obliterating the left true vocal fold. So you don't see that nice opening, that ventricle between the true and the false vocal fold. So I would probably document that as well. So this probably has no major impact. But perhaps if this uvula has been kind of sitting on the epiglottis for a long time, maybe there's some sensory loss there. Who knows? We'll have to jump into the bolus trials to know for sure. Okay, so this one, this image was not taken from a patient. This is actually someone who attended one of our FEES training courses. So these are the biggest lingual tonsils I've ever seen. I mean, these suckers are huge. And so we're going to definitely document that. And I went on to ask this person if they had any snoring or anything like that, or trouble breathing, and they didn't have any symptoms that they could perceive. So, and their resonance was fine. So I was really flabbergasted when I saw these ginormous lingual tonsils. But thinking about how the swallowing might look, when you think about the vallecular space and the piriform sinus, those cavities, those nooks and crannies are really there maybe kind of by design. They collect material as it sort of kicks its way back into your throat. And so if these spaces are obliterated, then there's nowhere for material to go. So according to Dr. Palmer and Matsuo in that paper they did, gosh, I think that was mid 2000s. They looked at patients eating cheeseburger, French fries, and they found that during the oral prep phase, folks had a tendency to collect material in the vallecular space for up to 10 seconds. And so if you don't have a little bit of space there, there's nowhere for food items to collect. So you might see food kind of spill a little bit deeper into the pharynx prior to swallowing. Okay, so this is something that we're going to have to really get descriptive with. This is not a normal variant. This is very abnormal. So here on the patient's right side of their posterior pharyngeal wall, we see a large protrusion. Okay, you could also say mass, and it is obliterating the right piriform sinus. And if you look down here, you can also see some whitish bumps along the right area epiglottic fold, down into the vestibule on the ventricular fold, and then on the left side as well. Thinking about swallowing, this protrusion here could impact bolus flow, but this is very concerning. It's asymmetrical. There's kind of this whitish kind of little bumpy coating in here. So for this patient was seen in the post-acute setting, and we did recommend an ENT follow-up, and this unfortunately did end up being cancer. So they were able to get down to a path for treatment for this. So we put pictures in our report and then put a really good description in there and really urged the referring physician to send them out for the specialist appointment. Okay, so there's actually a couple different things going on in this image. You have to really look around and not let one thing distract you so you miss other things that are going on. So first we see a protrusion from the left lateral pharyngeal wall here, likely bony or cartilaginous, but we don't really know what's underneath, so we just call it a protrusion. There's also a little protrusion coming in to the posterior tracheal space here. This could be like a cyst or something like that. We just called it a round protrusion. I've heard that this can sometimes, when it moves, can be sort of a weakening of the posterior trachea, sort of a tracheomalacia, if you will. But this is really beyond my scope. So I just document what I see, and then anything that has to do with the airway, I refer it out. So I would definitely say, like, there's a little bit of a protrusion here in the posterior trachea, because this could, if it gets bigger or expands, this could impact the airway. I would pass that along to our colleagues. And then if you look here at the base or the petiole of the epiglottis, this looks a little bit red to me. So I would just document that as well. maybe a little bit of an impact on bolus flow, but my concern is less about swallowing and more about airway integrity here. Okay, so here we have a large bulge at the midline of the posterior pharyngeal wall. This is quite large, and I don't have x-ray vision, but if my patient doesn't have a history of cervical spine surgery, I'm gonna probably assume that's an osteophyte, but I won't call it that because I don't know for certain. And my concern is that this could impede epiglottic inversion or recoil. And so I actually have a video, it's not the same patient, to show you of an epiglottis that actually gets stuck in the inverted position. It just kind of gets the bulging of the posterior pharyngeal wall just creates sort of a mechanical barrier that can inhibit the epiglottis from returning to its rest position. I had a patient one time that was coughing after almost every swallow, and so they called us in to do a FEES in post-acute care, and it turned out their epiglottis was getting stuck, and they were kind of expelling air to return the epiglottis back to its rest position. So that was one of those situations where you put in the report like they coughed, but it was, it was not in response to any prandial penetration or aspiration, that it was more like an anatomical thing. So, that doing something about an osteophyte is obviously out of our scope of practice. So I just pass that along to the referring physician. And if they're able to have any type of procedure, if it's changing swallow function, I would certainly pass that along. And okay, so this you might see every now and then. So here we have a coiled NG tube or Doppelhoff tube, Corpac, depending on the brand that you use at your hospital. It is kind of traversing the larynx. And if you can kind of not be distracted by that, you can also see that there's maybe, a little bit of redness here on the patient's right arytenoid, and then maybe a little increased edema on the right ventricular fold. Again, it's hard to tell in a still where they're not moving, but I would document that if that was there. So what would you do? I with it crossing midline like this, I probably would not proceed with POs. I would probably ask if we could have nursing remove the NG tube, then go ahead and do the swallow study. And then if they still need one, go ahead and replace it at that point in time. Okay, so we're going to move on to secretions. This is still part one. So I've been talking for like 20 plus minutes, and we're still in the anatomy and physiology section of our FEES protocol. And so secretions are very important. We know that if our patients can't manage their secretions, they're much more likely to have aspiration. So as we're looking at secretions, it's really important, just like the anatomy, that we describe them. So we're going to describe color, location, the amount, the viscosity, the clearing response, and whether or not the clearing response was effective in reducing the amount of secretions. There are a couple of rating scales that can be used with FEES, and I'll go over each of those briefly. There's the Murray secretion scale, the New Zealand secretion scale, and the Marion-Joy secretion scale. So the Murray secretion scale was the first one, to my knowledge, used to identify secretions on FEES, developed obviously by Dr. Joe Murray, and it is still widely used today. In fact, I did a presentation earlier this year talking about rating scales, and I did a little Facebook survey in one of the FEES groups, and just asked who's using what rating scales, and 44% of the people who responded are using the Murray scale. Another scale that I've not used in my practice, I used to use the Murray scale, but the Marion-Joy scale is also available. Only 3% of respondents to my little Facebook survey actually use this one. It is, one, I guess I should have gone over this in more detail. So the Murray scale, sorry to jump around here, but It's 0, 1, 2, 3 based on if the secretions are normal, where they are, if they're pulling outside, pulling in, or consistent pulling that is not cleared. And then the Mary and Joy is just a little bit more detailed. So it's also kind of like a 1 to 5 scale, but a little bit more detailed as far as, less than 10% in the piriforms or the vallecula, and then mild would be 10 to 15, and so on, to the secretions being to the level of the vocal folds and possibly even aspirated. And then what we use in our practice and have for a while is the New Zealand secretion scale. I really like it because it's pretty detailed, and it also looks at the clearing response in detail. They've also done additional research and found that people who score a 4 or greater on the New Zealand secretion scale do have a higher likelihood of developing aspiration pneumonia. So this looks at the location of the secretions, the amount in the piriform sinuses, and then the clearing response of the secretions. And then in my little Facebook survey, 23% of responders use this scale. And this is what we use, Patheos uses in our mobile fees practice. So let's look at some pictures. Okay, these are just stills, so we're not going to be able to say much about the clearing response. But this one I described as being sort of bubbly, frothy secretions. And then we want to talk about where they're in the piriform sinuses. They're at the posterior cricoid space. They're spilling over the arytenoids. They're spilling over the inarytenoid space. And then if you look a little deeper, there's secretions here in the anterior trachea. Okay, so if you're using the Murray scale, this would be a 3. There's pooling in the laryngeal vestibule that isn't cleared. The Mary and Joy, I just kind of taught myself how to use it. So if you use this a lot and I'm wrong, just let me know. But I scored it as a 5. It is, on the vocal folds, kind of on that medial aspect of the vocal folds. And then the New Zealand secretion scale, I scored as a 6. So the location was a 2. The amount in the piriform sinus was more like a 1. And I scored it a 1 because the left side is a little fuller than the right side. So I kind of took an average there. And then there's no clearing response, which you wouldn't know because this is a picture. But let's see. And then this one, gosh, this is what our patients look like who are NPO. And then we end up seeing them in post-acute care, and they have these like thick, kind of sticky secretions hanging out in their pharynx. And so these are tricky to rate on these rating scales. So first, let's talk about how we would describe it. So I call these copious, thick, white, sticky secretions. They're observed throughout the pharynx. They're filling the vallecular space. They're coating the posterior pharyngeal wall. And essentially, they're obliterating all visible structures. But the downside is I can't see all of the structures. I can't really see, because there are so many secretions everywhere, I can't really tell how full the piriform sinuses are. I can't really tell if they're in the laryngeal vestibule based on this image. Now, I'm going to try my darndest to get around there and see what I can see. But if not, we really have to lean on our description, because sometimes these rating scales may not be applicable. If this patient was stable, had like clearance to maybe go ahead and eat and drink, I would probably try some sips of water to see if we can clear this stuff out. See if I can get a Yankauer back there to see if they can expectorate some of this crud, and try to get them swallowing with a clean slate if possible. Okay, so here's another one, and I'm just going to be quiet for a few seconds if you want to try to think of how you might describe these on your own. Okay. And so I described these as white ropey secretions that were coating the left lateral channels in the piriform sinuses. You can kind of see them at this posterior cricoid space. And then it looks like there's a little bit of secretion down here. I called it stringy endolaryngeal secretions. So for the Murray, I scored this one as a 3. The Mary and Joy, I scored it at 4. You could probably debate me on that, but it's at least to the level of the true vocal folds. Again, it's a little tricky with a picture, but I didn't want to put too many videos in here. And then the New Zealand secretion scale, the location, I scored a 2. The amount, I scored a 1. And the response, I scored a 3 here for a total score of 5, which is an indicator for an increased aspiration pneumonia risk. Okay, so here's a video I'll play. It's a short one. So these secretions are just kind of pooling here at the posterior cricoid space. They're frothy, they're kind of whitish, and we didn't see any reflexive attempts to clear. So I scored this as a New Zealand 3, a Murray 1, and a Mary and Joy 2. So I also, if you're astute, you might have noticed that there are some kind of whitish lesions in here. It looks to me like granulation tissue, and that sounds in line given that this patient had been emergently intubated and intubated for a prolonged period. So that's very likely granulation tissue there. Whew, okay, so we got through part 1 of the FEES protocol. We looked at anatomy and physiology assessment. We did our non-swallowing tasks. We talked about how to describe abnormal findings using lots of very detailed descriptors, as well as putting images in the reports if we can. Talked about secretions. So now we're finally moving into bolus trials. So before we start talking about bolus trials, we have to think about what we're going to test. So some places I've worked have a rigid protocol that you use. Other places it's left to the discretion of the clinician doing the study. Dr. Langmore does recommend an ice chip protocol for medically fragile patients. So I think about my really sick patients, someone who's been NPO for a prolonged period. I worked at a hospital once that did lung transplants. And so right after a lung transplant, we would be really, really cautious about what we gave our patients. We didn't want anything to get into those new lungs. So those are all good situations where you might want to use an ice chip protocol. Patients in the ICU, where I'm seeing patients these days in the post-acute setting, my patients are generally pretty stable. A lot of them are eating and drinking, or at least they're getting chips and sips. So I may not start with ice chips. It just really depends on the patient. There is no time limit with bees. We all know that. So I do an extensive study. I give a lot of trials. We are transitioning to using digest in our practice, but we have modified the digest protocol. And if you're not familiar, we can kind of talk about this if there's time toward the end to add some more trials to that. And then at the end of my study, I always have the patient self-select food and drink. I add carbonated liquids if the patient is asking for them, or if I know for a fact they have some sensory stuff going on, or that's something they're really asking for a lot. We'll try to test that specifically on the study. Like I said, at the end of the exam, I do ask the patient to self-select, like just eat and drink at your own pace. I don't cue them. Like if there's residue, I just kind of wait and see if they're going to clear it on their own, if they're going to pick up the cup and take the drink. Really, sensory input feeds motor output. And so if we're sitting here just constantly feeding a patient, cueing a patient, we're not getting a good idea of what their natural swallowing looks like. And that's one of the beautiful things that is so wonderful about bees, is that we can do that. And sometimes we might think, gosh, their swallow's off, it's delayed, or it's weak, or something like that. Whereas if you just hand them the cup or you just hand them the fork, that extra sensory feedback to the cerebral cortex gives you a more robust and timely swallow response. So even if they're like a little shaky, try to do some trials where they're able to self-select. Dr. Bajans did a study in 2014 where they found that increased trials does lead to increased sensitivity. I believe, no, I can't remember. I think this was on like head and neck, maybe, and stroke patients. I can't recall exactly the population. And there's some debate over doing more limited protocols in our field versus more trials. But since I have the time to do my FEES exam and most of my patients are really stable and able to tolerate, if I'm going to put them on a diet, I do provide as many trials as I'm able to during my exam. I also really like to test mixed textures. Just a little bit about food coloring. Lori and Erin's webinar did dive into food coloring research, so I'm not going to jump into that in detail. Blue and green are the most widely used, and they have been researched to be better than not using food coloring. They're great colors to use because they are different than anything you would find in the body. I would definitely stay away from using like red or purple. And then there's been research, Dr. Butler did those studies showing that they found increased airway invasion with milk versus water. And then down the line, Dr. James Curtis has done a little bit of work looking at barium and white food coloring and has found that material that coats and is opaque, such as barium or white food coloring, does lend itself to showing more airway invasion and residue on your FEES exams. More research is needed on this. The studies that were done by Dr. Curtis used only like 5 and 10 ml bolus presentations, so we definitely need more. I don't use white exclusively. There's a lot of people talking about white food coloring these days, and I think it really depends on your equipment. Different equipment, it might show up differently depending on the quality of your scope. But for me, I really like that blue or green is translucent. And so I can see what's happening kind of through the bolus, whereas the white with a fiber scope, it reflects light back into the endoscope. So here's an example. These are stills from the same patient, 2 conditions. So this is blue dyed water. They have penetration before the swallow. And with the blue dyed water, I can actually see through it and see that the arytenoids are together, and it looks to me like the glottis is closed. And then they open up their airway again after the swallow, and I don't see anything in the anterior trachea. I don't see anything in the laryngeal vestibule here. But then when I gave them white dyed water, it was hard for me to see the glottic closure, the arytenoid approximation through the bolus. And then because this material has a tendency to coat, it looks to me like they didn't clear the material that entered the larynx. And so I'm not sure if that's because they're not able to clear it or because of the coating effect of what I'm testing. And I really don't want to overrate severity for my patients. So I'm going to look for a pattern. I don't always use white food coloring, but if I do, I use it just as an adjunct, and I find it really helpful for those patients you're working with who are just keep aspirating really quickly during the swallow, and it's so hard to catch it. Because of the coating effect, you'll see a little trail of the white food coloring, and that can be helpful for you to feel confident in your analysis of the swallow. But I don't exclusively use white food coloring. Okay, so let's get into identifying airway invasion. So we're giving our boluses. We're going to talk about swallow efficiency too, but we're going to start by looking at airway invasion. But what we're really looking at during part 2 of the Langmore FEES protocol is our overall swallow function, and swallow safety and airway invasion is a part of that. The PAS, the penetration aspiration scale, I assume most of you are very familiar with it if you don't use it every single day. In my survey for the SLPs who responded on Facebook, 90% use the PAS. So it's an 8-point categorical scale, was originally validated for use with the modified and later validated for use with fees. It describes the depth of airway invasion, and it also describes the clearing response. It does not describe physiology beyond just whatever the sensory motor responses that are there. And one thing I like to point out is that make sure your laryngeal boundaries are defined across your team. So the laryngeal boundaries that are defined, say, in this paper or a paper from another researcher, a lot of these big names that we know in dysphagia don't have the same definitions for laryngeal boundaries. So we just got everyone in our practice on the same page of using what Dr. James Curtis has defined. These are the VASIS boundaries. So if you're on the same page with the laryngeal vestibule boundaries, your team is already going to be better at being on the same page in defining what is laryngeal penetration. So these are a little deeper than some of the definitions. So laryngeal vestibule is really going to be anything inside the bowl. So you can see these drawings here. If it's on the rim, I say a lot. If it's on the rim, it's not in the bowl. So if it's on the edge of the area epiglottic fold, on the arytenoids, on the tip of the epiglottis, it's not airway invasion. And then with aspiration, we're looking at any material that is inferior to the vocal folds. So if it's medial, if it's on the vocal folds, it is not aspiration. So making sure that that's defined. So what's the why? We really want to dig into physiology here. So the timing of airway invasion gives us a lot of information about the reason for airway invasion. So if it's happening before, might be a timing issue. We might be losing stuff over the base of tongue. If it's happening during the swallow, we're not closing the vestibule, either the top door, which is the epiglottis, or the bottom door, which is the glottis. If we see airway invasion after the swallow, typically this is residue that's not cleared or backflow or something like that. If we're not sure, sometimes we do need to do a frame-by-frame analysis, and I do recommend doing the slow motion frame-by-frame with your studies, especially with the bolus, with the swallow conditions that you want to double check on. And then taking the information that you got about the non-swallowing task is helpful here too. Okay, so I have a couple of examples. So I'll play real time and then I'll play slow-mo. Oh, let me try that again. There we go. Okay, so that happened really quickly. So I'm going to now play this in slow motion, and it might be a little bit easier to see that there's really fast pre-swallow airway invasion here. Okay. And if you missed it, next, I'm going to show you what the frame by frame might look like. So we have before the swallow, still kind of starting to swallow here. Over here we have, you can see that the arytenoids have approximated, but that the material has started to spill over into the laryngeal vestibule. We have whiteout. So this is a fiberscope. You get that bright whiteout. You get more of a pink out with a video scope. So then I'm going to look at the first frame after the swallow. I can kind of see the underside of the epiglottis in that frame. This frame, I really see it. And then the airway looks pretty clear, but I can only see the anterior trachea. So I can't say for certain that there wasn't leftover material in the posterior trachea because the entry point for that airway invasion was posterior. So I saw the arytenoids medialize. It didn't really look to me like they cinched in toward the base of the epiglottis. So the valving at the level of the glottis isn't there. The epiglottis, when I did my frame by frame, appeared complete, but looks like the timing was off because the material did enter the airway before the swallow. the material collected in the piriform sinuses, and then it spilled through the inarytenoid space into the airway. There was an immediate cough. I think slash hope it was fully ejected, but I can't say that with 100% accuracy. Posterior aspiration might be a little bit easier to see on the modified. Okay, so my next step would be to do another trial or maybe do a bolus hold swallow and see if we can improve the timing of the swallow. Okay, so here, and I saw this question. It's hard for me to watch questions while I'm presenting, but with fees, the first action of the swallow is the onset of medial movement of the arytenoids. This happens 0.34 seconds prior to the onset of hyoid burst. So intentional medial movement of the arytenoids toward the midline is the first action of swallow onset that you see on fees. Okay, so let me play this, oopsie, let me play this video again, maybe. There we go. So this is a bite of mixed texture. This is a little bit of a liquid that kind of spilled down and touched the true vocal fold before swallow onset, and then kind of hovers around there. And then you see the solids kind of make its way down. So this is a mixed texture. Frame by frame, here you see the liquid. It looks like if it has reached the true vocal fold. Then I have whiteout. Looks like I have some, I kind of see the underside of the epiglottis there. So the epiglottic did invert at least to some extent. And there's just a little eensy weensy bit of trace material at the anterior commissure there. So liquid entered the vestibule before swallow. I surmise this is posterior loss. So they're just kind of losing the liquids over the base of tongue. We see this sometimes with cognitive communication deficits or inattention. Or sometimes you could see this with just reduced base of tongue retraction, kind of sealing off that oral cavity. There's likely a sensory motor deficit. There was no clearing response for that little bit of penetration there, but it was a really trace amount, but it was not ejected. So next I would cue the patient to clear their throat. And then I like to do a couple of trials as long as my patient is stable to see if this is a pattern or an outlier. Okay. So here I have another example for you with airway invasion. And so there is kind of the liquid material just kind of whooshes over, and this looks like during the swallow. So I'll play it in slow motion for you. And then we see aspiration in the trachea that happened during the swallow. Okay. Yeah, so you saw the arytenoids had started to approximate and the material was kind of spilling over the tip of the epiglottis, and it entered during the swallow. So we go back to our frame by frame here. It looks like the epiglottis is kind of delayed or sluggish with inverting, and we already have liquid material in the vestibule. We did get some inversion here. I can see the underside of the epiglottis. And then when they open up, I do see that the material was aspirated, and it was silently aspirated. And this is, both the top door, the epiglottis, and the bottom door, the glottis, are not doing their job to protect the airway there. The timing was delayed, and maybe also a little incomplete as well. And then we definitely have sensory motor deficits. So there was no reflexive response to clear it. So I would cue the patient to cough at this point, and then I would do another trial if appropriate, changing the bolus delivery method. Was it a cup sip? If so, let's try a straw, or vice versa. Try a bolus hold. I love the bolus hold swallow. It works so well a lot of the time. Or move on to a different texture if you need. Okay. I am really trying to get through all of this. So I'm going to kind of go as quick as I can through talking about pharyngeal residues. So we're still in the bolus trial portion of the protocol. So there's really two camps when it comes to looking at pharyngeal residue. with fees. One is how full is the cavity, and the other is how much bolus is left behind. How much bolus is left behind is a little bit tricky because unlike our friend the modified, we can't see what has passed through into the esophagus. So it's really a lot of guesswork. Um, Dr. Steele did some work looking at the modifieds and found that actually um, doing what do I have here? Oh, okay. So when we're looking at the percent of the cavity full, that is actually less accurate than looking at how much bolus is left behind. Now, this research was done using modified, which is another way to look at things. And they used a pixel-based method and found out that was actually the best way to examine residue for the modifieds. I have been using a how full is the cavity approach for many, many, many years. I guess for me, I was really thinking we're all different shapes and sizes, and the nooks and crannies in our throats are all different shapes and sizes. And so one person can maybe tolerate more material in their nooks and crannies than someone with more shallow cavities. However, Dr. Jess Pasegna did some interesting research and actually found that looking at a visual analog scale is actually better than any of these ordinal scales. So all of these how full is the cavity scales, they're all ordinal scales. The only rating scale that has been validated for fees that looks at a visual analog approach is the digest. So I'm going to try to get to that. So the Yale residue scale really just is an ordinal rating scale looking at how much residue is in each cavity, the vallecula and the piriform sinus. Okay, the Mansura rating scale, I've not used this, but in my little survey, no one else was using it either. A fair amount of people use the Yale. The Boston residue scale, gosh, it came out in like 2012, 2014, 2013, I think. And it's just really detailed. It takes a really long time to use that rating scale. And they're supposed to be coming out with a more truncated version that's more applicable to practicing clinicians and not the research setting. But to my knowledge, they haven't come out with that yet. So the Mansura scale is a little more detailed than the Yale residue scale, but the same concept. It's an ordinal scale looking in the vallecula and the piriform cavities with the rating from 0 to 6. Okay, so when we're looking at rating scales, it's also important to really understand the physiology, not just how we're rating the residue. And knowing the location of the residue can give us an idea of what is going on with the physiology. So nasopharyngeal residue might indicate that we don't have really good tight BP closure. Vallecular residue might be due to reduced base of tongue, pharyngeal constrictions not quite right, or incomplete laryngeal elevation. Piriform sinus, we might not be shortening the pharynx to allow the material, the pockets to empty, the piriform sinuses to empty into the upper esophageal sphincter. There could be reduced laryngeal elevation, not tractioning open the UES, or the UES isn't fully relaxing to allow material to pass through. If material's on the laryngeal surface of the epiglottis might not be getting out of the way in time. And so it's getting a little residue there. Same with the arytenoids. If we're penetrating and it's on the surface of the arytenoids, my guess is maybe they medialized, but they did not cinch in toward the base of the epiglottis to fully close off that bottom door to the laryngeal vestibule. And then posterior cricoid space, we're not clearing through the UES. Either it's not open long enough or not open wide enough. Base of tongue function is really better seen with the modified. With fees, we're really relying on our non-swallowing tasks and looking at the symmetry and the pattern of movement. Hyolaryngeal elevation, obviously we can see that so much better with the modified. With fees, as you saw in the previous examples, we're really using the epiglottis as an indicator. Pharyngeal function, using those pitch glides and dry swallows for your non-swallowing tasks, this translates really well into pharyngeal clearance, and then valving forces, looking at glottic closure during our non-swallowing tasks, and just looking at how the airway protection looks with swallowing. So we'll practice a little bit looking at the residue. We'll quickly go through the scores here. So this is somebody, I believe they're eating fruit cocktail. And we have a couple of cherries just sort of left over here in the vallecula, more on the patient's left side than the right, but definitely filled to the rim. So we're going to give them a liquid wash to clear. And it's coming. There it is. So, and that minimizes the residue for this example, but it doesn't fully clear it out. So we're going to have to try it again or try some other strategies for that. So for the Yale, I know I'm going fast, you guys. I'm sorry. I said moderate because it's halfway full. The Mansura, I said it's a 3 because it's touching the epiglottic rim. And then the Y, so Dr. Humbert says that base of tongue is what gets the epiglottis to horizontal, and then it's pharyngeal squeeze that pulls it the rest of the way down. So I'm guessing that there's all of the above. We have some reduced base of tongue retraction as well as pharyngeal constriction and likely reduced hyolaryngeal elevation as well. Maybe we're not feeling that little bit of residue. I'd have to go back and listen to the video to see if the clinician prompted the liquid rinse. And then we'll confirm the physiology, just going back through our video, slow motion. Okay, so this patient, this is pureed. So we're like really moving around a lot to orally manipulate a smooth puree. This is applesauce. And then we see residual after the swallow. It has completely filled to the top of the epiglottis, so full to the rim, but a really tiny little vallecular space there. And then we also see a little bit of residue in the piriform sinuses, just a trace amount. So on the Yale, the vallecular portion would be severe, filled to the rim. The Mansura, the vallecular portion, we would say it's overflowing, maybe pooling, which would be a 5. I think this is due to reduced base of tongue retraction and pharyngeal constriction. It looked like the base of tongue, maybe they were having some A to P transfer difficulty. It just looked like a lot of movement to manipulate that pureed. And then we'll confirm with our video playback. So I do want to take a minute to talk about these rating scales that have both safety and efficiency components. So we've talked about scales that are just really targeted for either looking at airway invasion or looking at residue. Well, these scales look at both. So the VASES was created by Dr. James Curtis. It implements the PAS and then its own residue scale. And you can find tutorials on this free of charge if you go to Dr. Curtis's website. And then the digest was originally created, validated for use with the modified, but it's since been validated for use with fees. And it's also a great scale. It uses the PAS to generate a safety grade and then a visual analog scale to generate an efficiency grade. And then you come up with an overall score combining the two. Dr. Curtis has done some work. It published in 2024 showing that you can use VASES to derive digest scores. So I think there might be some more research coming out on that. Now, I did survey who's using these scales, and on my little informal survey, 43% of feesers were using digest. 15% of were using VASES, and then the other stuff was kind of just everything. I think the most common one I saw was the DOS, the Dysphagia Outcome Severity Scale. What about the esophagus? So with fees, you're going to possibly see indicators of an esophageal component. So maybe on your anatomy and physiology assessment, you see inflammation, you see some post-swallow residual at the UES or residual that worsens over time. If your patient is complaining of food still feeling stuck or a globus sensation, and you can ascertain that everything has cleared out of the pharynx, then, they might have something going on further down. Or coughing without airway invasion. We have cough receptors all along our esophagus. And so sometimes that mystery cough is just because there's something else going down, and we do need to make a referral out to, depending on your hospital, sometimes the ENTs take the upper esophageal stuff. Sometimes you pass that to GI. So, okay. Now we're at part 3 of the FEES protocol. So we did anatomy, physiology, talked about secretions. We did some bolus trials. We talked about airway invasion, using rating scales for that. We talked about residue, using rating scales for that, as well as rating scales that look at both safety and efficiency. So now the final part, and my favorite part of the FEES protocol, is the assessment of intervention. So we have figured out what's broken with our patient swallow, and this is where we figure out how to fix it. So this is requires some online thinking. So if you're new to FEES, don't be hard on yourself. It can be hard to think on your feet with this stuff. But we're going to try different strategies here. So thinking about what you learned as far as what can minimize residue. And I always recommend, or prevent airway invasion, I always recommend starting with the least invasive maneuver or strategy, just for simplicity's sake, but also for our patients' dignity. If they're eating in a dining room, they might not want to do, stand on their head to eat and drink. So thinking about that. If you're working with patients with long-standing dysphagia, a lot of times they're already beginning to self-compensate. Our cerebellum does us some big favors of using error-based learning. And so that's why it's so important to give our patients opportunities to try, even if they're having a disordered swallow, to see if we can get back on track. And so if you can perceive that they're already doing some kind of just, they thought of themselves modification. I do see people doing effortful, or even like a slight breath hold before the swallow. I'm going to kind of grab that as the first strategy that I try. You can also test exercises on your FEES. There's not a ton of research on this, but Dr. James Curtis did publish a paper, and it was in Perspectives, on what maneuvers and exercises are best seen during biofeedback with FEES. But patients who might have cognitive communication deficits, I really like to be able to give them a visual and then cue them when they're doing what I've asked them to do. So that's really good. And then if you're giving a lot of cueing, just making sure that you're documenting the cue, so that if you're out the next day, your colleague can offer the same cues and elicit the same behaviors that you did. Okay, so I have just a couple of examples, and then we'll wrap it up. We're just really just taking it all the way to the end. So this is a patient with a delayed swallow. So we're doing nectar or mildly thick. A lot of the post-acute buildings we go to still use the NDD terminology. So we adjust our language for them. So that's why it says nectar and not mildly thick on this slide. So you can see the patient has the material, it's reached the vallecula. You see some kind of movements like they're starting to trigger a swallow, and then you'll notice it'll kind of just cease. So they're just not swallowing, and they're not swallowing, and they're still not swallowing. So the clinician says swallow, and then you might see a little bit of, maybe we're thinking about swallowing. The base of tongue starts moving again. She does a couple more verbal cues, and then somebody actually does give the patient a spoon, a dry spoon, and they do eventually swallow. So it's going to happen soon. This is quite a delay here. This is a cup sip of nectar. This is one of those delays you feel in your gut, and you're just like, okay, please swallow. Oh, phew. Okay, we finally swallowed. So now what we're going to do, same texture, mildly thick. We are just going to give it to this patient with a straw instead of a cup. I want you to watch how timely this swallow is. here it comes. Boom. Like you don't even see it. It goes so fast. So just changing the bolus delivery method, that's it. That extra movement of wrapping our lips around the straw and sucking prompted a more robust swallow response. Oopsie. So this patient had a epiglottomy. This patient had a lot of cervical spine issues, and they did not like to sit up. I was doing the fees with them at like maybe 30 degrees. And so, as you can see, this patient had a PEG, and they had airway invasion with the pureed trial. You see airway invasion with the thins. If anyone else is in North Carolina, I don't know if you've ever had a Cookout milkshake, but all she wanted was a milkshake from Cookout. And so all I did was coax her to sit upright, and we found neck pillows and all of that. And as you can see, the swallows in the upright position. I mean, there's like a beautiful swallow there. It's not perfect. She doesn't have an epiglottis, but it's way less risky. So we were able to recommend POs for her while sitting upright and just encouraged her not to sit in that reclined position. And so just she needed that visual and that education to really coax her, take, what pain meds you need to be able to sit upright. I'm gonna skip this last one just for the sake of time. So it's really important to make sure that we're doing all three protocols in order to give our patient the exams that they deserve. Okay, so making sure that we're looking at the anatomy physiology to make sure we're analyzing secretions, we're doing an in-depth analysis of their swallow, looking at the physiology, using rating scales to keep us honest. And so we have good inter and intra rater reliability. And then if they have a dysphagia, figuring out how are we going to improve safety and efficiency while we work toward rehabilitating their swallow. So we've been really specifically talking about swallow, but we can't end a presentation without talking about the big picture. So we do have to understand our patients' goals and their relationship with food. Do they eat to live or live to eat? We like to call everything throw exercises at everything, but it's not always a strength problem. Sometimes it's a structural problem, a timing or coordination problem. And so keeping that in mind as well. And then if you can't tie a dysphagia to another medical diagnosis, we might need to make some referrals. So keeping that in mind, can we draw a line from the dysphagia to something else? We do make diet recommendations in our practice, but we do make sure that it's the patient's decision. There might be something that is safer or improve swallow safety or efficiency while we're working to rehabilitate the swallow, but that is the patient's decision if they want to adhere to that or not. And then if they need repeat, it's important to document that. Especially if you're in acute and your patient might be going to rehab or post-acute, if you put it in your documentation that they need a repeat, they're more likely to get it. Your friends in the post-acute are fighting really hard to make sure they have access to imaging. And so you're supporting them by putting that in there. There was a study they did where they found patients at post-acute, they did fees in day 5 after admission. This was with the stroke population. And I think all but one ended up with a diet upgrade. So these patients get better. They need access to imaging. So one of my favorite colleagues always says, we're not the aspiration police, we're the aspiration pneumonia police. So just aspiration isn't causing pneumonia. We need to get to the bottom of what's going on with them and make appropriate recommendations and understand the risk factors. There's some papers that do an excellent job. The most recent is work by Palmer and Padilla looking at the bolus framework. So we can't control if they have, poor immune system, their lungs are sick, but we can control making sure that they not only have access to imaging, but they have access to quality dysphagia imaging with a clinician who knows what they're doing and is going to give them a fair study. And then we have to keep fighting the oral hygiene fight. I know we get so sick and tired of it, but it's so important. So with that, I will wrap things up. Thank you so much for your time. Yes, this is bow tie pasta sitting on a patient's just in the perfect spot in the laryngeal, just above the laryngeal vestibule. So our website is on here. If you're interested in learning more from me or from my team, we do FEES training and FEES mentorship. You can also email me. That information is there. And I have all of the references listed here. And Brooke can I think email you all the slides. So what
Yes, thank
questions
you
do we
so
have?
much,
Yeah,
Lena. There's
yeah.
a ton of questions in the Q&A in the chat, so I'll go over ASHA CEU stuff if you want to take a look at those.
Okay.
So I saw there was several questions in the chat and the Q&A about ASHA CEUs. So just a quick recap, if you missed it, the survey that is corresponded to this course will need to be completed within 7 days, and that link is in the chat, and it will also be sent out via Zoom. And then if you'd like a certificate of completion, just send us an email at tims-unum@tims.com. The replay for this event will be up on the website within 48 business hours, as will the slides. So with that, I'll hand it back over to Selena to answer some questions.
Great. Yeah, I'll try to get to as many of these as I can. And sorry, I had to kind of rush through. I always do this. I put too much information in. Okay, so Karen, I recognize your name. When there is asymmetrical movement of the arytenoids, I have trouble discerning which one has less movement than usual and which one is restricted. Yeah, oftentimes if you look closely, you'll see that one side is kind of overcompensating for the side that's immobile. Someone who has more experience in voice might be better able to describe that than I can, just being more of a swallowing clinician, diagnostician. So I just usually look like, oh, usually you can tell that one side is kind of overcompensating. And I have to think, okay, is that the right or the left? But hopefully that answers your question, Karen. And if you want to reach out to me, I can talk to you in more detail for sure. Hannah, describing copious secretions and using the New Zealand. If you were able to clear those secretions, would you score what you saw before and after, or just after? Good question. So I wait like a minute or so while I'm looking in my anatomy and physiology portion of my exam. And if they don't clear it in that time, then I score it without cues. So if I then cue them to clear it, then I would do the score before and then I would describe. So in my narrative, I'd say, significant secretions, however, water boluses provided and secretions cleared, patient not able to independently clear secretions. So I would not just rate it, I would also put that additional information and whether they cleared it on their own over time or if you had to provide a bolus or a cue to clear secretions. Okay. Do you always refer to laryngology for suspected intubation findings? No. Now, it's been a minute since I've worked in acute. I've been in post-acute for quite a while. So it really depends. I document and let the referring MD know. So whether that's the hospitalist or whoever, because that's usually going to go away. It's like a scab. Granuloma tissue is like, it's kind of like a scab forming over an injury while those cells turn over and heal. And so it's not, but if you're not sure, if they weren't recently extubated and you're like, what the heck is that white thing in there? Definitely call laryngology. But if you can tie it to something and you're in acute, you're in the ICU, you may want to just let the attending know. And if there's people who have different ideas who are more recently in working in the ICU, feel free to chime in if they have a different answer than I do. Um, Okay, when you see penetration entering the vestibule posteriorly over the arytenoids with suspected aspiration, and you are unable to say for certain whether there was clearance, yeah. Okay, what do I say? If I'm not sure, I say I'm not sure. I say if it looks like it cleared, like sometimes you'll see blue pop up with a cough. I'll say suspect material cleared, but cannot rule out trace aspirate did not remain in the posterior trachea. Um, I'm going to give a lot of trials. I might even try a swallow or two with the white food coloring, but yeah, if you're not sure, it's okay. It's okay to say I don't know. And if you really can't get the information you need with the fees, it's okay to do modified. Yeah, so that's what I would do. Okay. Do you have any tricks for being able to identify posterior tracheal aspiration? If patient coughs, then I guess we can kind of see the material come up. Yes. But are there any other tricks? Yeah. I mean, so Dr. Pasegna, this is an interesting topic. So we debate because we do mobile modifieds now too. And we have this debate sometimes like, oh, well, you can only see this with the modified. And it's like, yes, but the research using simultaneous fees and modified has discerned that fees is more sensitive than a modified and has identifies residue in more anatomical regions than the modified. So I don't think it's happening enough for the research to show that we're missing a lot. And this is research where they're doing simultaneous fees and modifieds. I know we want to catch every single thing, but if you give enough trials and you're doing your deep subglottic view after every, you're not putting the scope subglottic, but doing that deep post swallow view after every swallow. And if there's enough that adds up, you'll eventually see gravity take it to the anterior trachea as well. So hopefully that makes sense. Okay, on the super delayed swallow, when you see the light source in the airway, was there anything in there? I don't think so. I don't think there was, it was kind of a dark video, but yeah, I don't think there was material already in the airway. The light was secretions, very trace dye. Um, I hope this makes sense. Yeah, I think I know what you're saying, Ashlyn. I think you're saying when you see light kind of reflecting in the airway, how do you know that if there's something there or nothing there? Just practice. Looking at a lot of studies, leaning on your mentor. So we're still using fiberscopes in our practice. So the light reflection can be tricky sometimes, but I'm so acclimated to that. When I go to a course and we're using distal chip scopes, it takes me a minute to realize what I'm looking at. And with the distal chip scopes, you tend to see more orbs, which can be a little distracting as well. But the light reflecting can mean that you're close to tissue. It could mean that there's like a little bit of a sheen from secretion. So that's why it's really important to get a really good baseline view. And if you're not sure, you can always take an image and then compare it to the beginning. So if you're like, is that aspirate or is that the same as baseline, you can do a side by side and see if you're missing anything. That gets easier as you get more proficient with fees. You don't have to take as much time to do that comparison. I hope that answered your question. If not, feel free to reach out. Secretions clouding up the scope. Besides all the side swiping, yeah, if it's safe to have your patient take a drink of water, that's the best thing. I know we like to use ice and ice water, but in working with a lot of geriatrics, I found that sometimes even warm water can be helpful if they have those really goopy, thick, like that. I think we had one picture with like the thick, cruddy secretions. Sometimes that helps clear it out. Again, you have to look at your patient if they're safe to maybe the risk is they could aspirate a little bit of the water that you're giving them to try to clear the secretions, but a water swallow is usually helpful. If you just have a bunch of boogers on the end of your scope, if you just retract the scope a touch, sometimes gravity will just drop it down. But yeah, if it's so goopy that you can't wipe, and then the worst thing you have to do is pull it out, wipe it, and go back in. But that's an option as well. How low is appropriate to go in the larynx when checking for aspiration? I feel like there isn't enough light to adequately see. Yeah, depends on your system. Right after the epiglottis, yep, bounces back just for a moment so that I can go back frame by frame. Yeah, that's great, Brian. Yeah, I mean, when I teach fees, I say don't be afraid to get close, but you certainly don't want to tap and trigger a laryngospasm. So it's a sweet spot. So I just think of it as like you're shining your flashlight into the glottis to see as much as you can into the anterior trachea. Make sure you can see beneath the petiole of the epiglottis at the anterior commissure, because that's where material likes to collect just with the way that we're positioned in gravity. But yeah, if you can't catch it in real time, it's okay to say, you know what, I really need to go back and review this study, and then go back and do your frame by frame, just as you said. But just think about being able, and some patients you don't have to go as deep as others. It really depends on how their anatomy is. But deep enough that you can see anterior commissure, anterior trachea really well. Okay, I'm going to do this last question, but it is 9 o'clock, so I know I don't want to take anyone's time. So, if the retinoid does not move, does that mean there's paralysis? No. I say reduced movement, but I'm not doing strobe. And so I don't know that there's not like a little bit of movement that I'm just not perceiving. So you can say appears immobile or reduced movement of the left, right side overcompensating, but we don't know for sure why that's happening. So I just describe what I see and then refer. Good question, Stella. Yeah, thank you. Thanks so much, Brooke. This was
Yeah.
fun. I enjoyed it.
Thanks, Selena, for being here, and thank you all for being here this evening. I know there were a ton of questions, so feel free to reach out to Selena or reach out to our team at Tim's. And like I said, this recording will be on the website this evening or Friday. Can't keep my day straight, as well as the copy of the slides. So thank you all again for being here, and have a great night.
Thank you. Thanks, Brooke. Appreciate it.
Bye, everybody.